think we are ready now. Okay. So you know that the clinical expression of the otosclerosis depends on the pathology itself. We have the most common form is the fenestral form of otosclerosis that we can really nicely see in most of cases by CT scan. We have already this discussion when to ask CT or when we can do not any scan, but we usually do CT scan in almost every case to state the disease. So we can face a fenestral case, and then we know that the clinical expression of most cases of fenestral otospongiosis will be the classical one. The conductive hearing loss mainly on low frequencies with the notch on 2 or 4 K. So this is our most common cases of otosclerosis. But we have also the cochleofenestral expression that involves all the optical capsule around the cochlea, also the fissura antifenestron, the region anterior to the stapes flute plate. So this is a more aggressive disease, and the clinical expression of this type of pathology of otospongiosis is more aggressive, of course. We have always more young ladies or young guys. This lady has now 43 years old, but started with progressive hearing loss in her 20s after pregnancy. And the expression audiologically is a mixed hearing loss. Also, we have the conductive component, but we can see that the inner ear is receiving some aggression, is damaged about the progression of the disease, relate to the progression of the disease. So the last expression is the most aggressive forms of cochleofenestral disease, that all capsule, optic capsule can be involved in the posterior labyrinth, and severe mixed hearing loss can be discovered in this case, can be diagnosed in this case. So why can we deal with this more aggressive diseases is why we start to think about the clinical treatment. Because if we like to treat otospongiosis, we can divide the treatment in two phases. Treat the disease itself and treat the hearing loss. So to treat the disease itself, there is only one option, is the clinical treatment, because the surgery will not stop the progression of the disease in cases that this patient has a progressive one, a progressive kind of disease. So this is why we start to use regularly alendronate. Alendronate, all you know, it's a biphosphonate, and we can use it orally, and I will show you how we do this in a few instants. So in which cases we can use it? For instance, this is a 41 years old lady, sensory neural since her young, started around 19 years old. He had stape surgery on both sides, but without great success. The disease progressive, and then she has now this kind of mixed profound hearing loss with poor benefit with hearing aids. What can we do? Because she has already done the surgery. So she presents a juvenile form of otospongiosis. I think younger the patient, the chance of a more aggressive disease is higher. So in this case, I believe that the clinical treatment can help very much. In this particular case, we start alendronate, 7 milligrams per week, once a week, and look at the result regarding the hearing. And look at the result regarding CT scan. So we can really manage to stabilize the progression of the disease. We can compare for the first audiometry. We had a huge improvement of the hearing both bone threshold and air threshold in the right side, and even less improvement in the left ear, with improvement also in the speech recognition scores. So I think in this case it was very useful, the use of this. And maybe if we could stop the progression just after the first surgery, we could provide a low progression and maybe save this ear from this status. Another case, this is an interesting one. Another young lady, 27 years old, complains of tinnitus left side since 1 year. The audiometry showed this kind of sensory neural hearing loss with still good speech threshold perception. And you see presence of reflex and good speech recognition. So what can you do for this? We usually ask for a magnetic resonance because it's a young patient. And what we see here, this is a T1 without contrast, gadolinium, and then after gadolinium. You see always lateral in the Ototic capsule on the cochlea, both at right and left. She presented at that time an active focal Otospongiosis, and we hardly see any disease on the fenestral site that was typical for the fenestral form. So this is probably, our diagnosis was probably a cochlear Otospongiosis expression, and we start the clinical treatment, and after 1 year, she presents a huge reduction of this active disease in the cochlea, around the cochlea, comparing with the previous one and the second one. And her hearing remains stable, maybe with a little improvement here and still good speech recognition. We recently published some our initial results on the control of the evolution of this disease by image studies, but we think that the most important thing is to avoid the progression of disease and stabilize our surgical results. So treatment for hearing loss involves, in our point of view, the medical therapy for this kind of aggressive surgery, in any cases with a sensory neural component. How we do this? So as I told you, we use a Laercio once a week, and initially for 6 months. In every case, we mixed or pure sensory hearing loss. We can extend this treatment for 1 year in the more aggressive forms. We can use it in short times to stabilize surgical results when we detect inner ear aggression. We can use 3 months to stabilize the surgery prior pregnancy and in younger patients. Could be a good strategy to protect young ladies with confirmed disease that intend to be pregnant. We can prevent inner ear aggression in systemic osseous disease like osteogenesis imperfecta, mainly osteogenesis imperfecta. And clinical hearing, how are the cares we can do with this treatment? Well, we're monitoring clinical and audiologically each 3 months, and we do a careful oral evaluation, and we ask for a dentistry treatment if necessary at the beginning of the treatment or before the treatment, because you know one of the main complications of the use of biphosphonates in a relatively long period is the necrosis of mandible. But I can assure you, and the literature shows us, that this is mainly common in patients with oncological metastasis, that they use huge doses of bisphosphonates intravenous. With the oral treatment, this reduces a lot of this kind of complication. It's very rare. And another option to prevent the aggression of mandible is to have a good condition of the teeth. So a dentistry evaluation could be helpful in prevent some kind of complications. So to treat the conductive component of hearing loss, of course we can have the hearing aids and the surgery. And we're discussing about surgery. I don't have to discuss this because you are seeing the most update forms, but when a lendonate, for instance, can help surgery, in this case, a 27-year-old physiotherapist with osteogenesis imperfecta present progressive hearing loss in the last 7 years. He used hearing aid, but with difficulty because during his work period, he do a lot of effort, physical effort. So there are some sweat and the hearing aid blocked and they had a short time of duration, so he wasn't happy to use and not good fit with the hearing aid. But she had a regular fenestral focus, despite of being with osteogenesis imperfecta, and the classical expression of hearing loss, mainly a conductive component with a shaft a little bit higher than usually in 2 and 4K, without reflex and good speech recognition. So we tried to protect her with a lendonate for 1 year and do a stapedectomy after 10 months of a lendonate. You see it's an old case in 2006, 10 years ago. But we can see that the surgery could be made without any other complications. We use also this complete triphon prosthesis in our case until today. And she presents a very good result on the left ear that the one operate. We can compare with the previous audiometry. The osseous threshold are very sustained with a reduction of the knot. And she was happy also because her densitometry was almost normal first time in her life. So maybe with this kind of treatment, this kind of view, we can prevent the progression for the more aggressive hearing loss to very severe case and avoid maybe the cochlear implant that is also possible in this case. So finally, what is our view about the benefits of the clinical treatment? To inhibit inner ear damage in more aggressive forms, to stabilize surgery results when detect inner ear aggression, prevent inner ear aggression in systemic forms of disease, osseous disease, and stabilize disease prior pregnancy in younger patients. We are finishing our first data analysis of our data about the clinical treatment, around 100 cases. It represents a little less than 20% of our case of Otospongiosis. So we think we will need the clinical treatment in around 20% of our patients. It's not that much, but it's important. We have a stable hearing in 70 cases, improved hearing even in sensory hearing loss in 30% of cases. No side effects so far. And we have some progressive hearing loss along years, maybe involved in reactivation of disease or maybe other factors as presbyacusis or any other present disease, clinical disease that can compromise hearing. But anyway, I think it's an interesting point of view, and I would share the opinion of this great guy that has a great experience with surgery. And I appreciate your attention. And if you want to come to São Paulo, it's not a beautiful city as Béziers. We will get lost in the middle of this, but you can send us an email and I can guide you over there. And we will have our second year Brazil next October. Maybe you have a chance to be with us. Thank you very much.
So I'll second that about Sao Paulo. They say when you go to a big city, if you look out over the wing of the aircraft that you're in and you can't see the extent of the city, it's a big city. In Sao Paulo, you can look out over both wings and you can't see the city. Huge, huge. How many ENT specialists in Sao Paulo?
In the city of São Paulo, 2,000.
Okay, so 3 times as many as the UK. Okay. So, yeah. So, questions for Oswaldo?
Thank you for your talk. What is the follow-up time of these patients if you say there is a stabilization? For how many years is this? How many time? No, I mean in your study now with alendronate. Okay.
Cannot only ask the patient to come if he presents some new symptoms. New, about your opinion.
I just wanted to, first of all, congratulate you on this work because I think this is revolutionary. I mean, this is absolutely cutting edge what you're doing. I know in the U.S. a lot of people are talking about this, but I don't think anybody has this kind of experience. So I think this is groundbreaking. The one concern people have raised is using bisphosphonates. We're not familiar with it. There are some side effects and complications, and also the need for bone densitometry, which I don't know how to order. I mean, do you work with a rheumatologist, or how do you give this? You know, do you just write the prescription, or how do you do that?
When we have a patient with systemic osseous disease, also of course we have the contact with the orthopedic specialist. But in health patients presenting only capsular optical disease, we don't have usually any help of anybody. We just take care, and you are right about the fear, especially in the United States, about the side effects. I put it here. And, but I can assure you that if you use oral bisphosphonates in regular dose for this period, 6 months, and maybe in more aggressive cases, 1 year, the risk of this kind of complication is very low. And we don't need densitometry to control, we don't need clinical control. And one thing that the dentists call attention to prevent the necrosis of mandible is to take care and have a good condition of the mouth. So this can also reduce the risk. But we don't think for this time of clinical therapy, the risk is low, and we don't need any further assistance or tests. I don't know if I answer your question. Any other question?
Thank you, first of all. I'm Vladimir Rubio from Valencia, Spain. Yeah. It's only this treatment with alendronate, okay, is for stabilize inner ear pain or after surgery. But for example, one patient that come to with you and talk about hearing loss 2-3 months progressively. First, you try a corticoid treatment, or directly you think in alendronate, or how do you do it? How do you use the corticoids associated with this treatment?
Oh, I don't know what is the view about the panel and other colleagues, but I don't think corticosteroids has any indication for otosclerosis. We think that the main mechanism of inner ear aggression is high activity of osteoclast and enzymatic molecules that can reach inner ear cells can damage the inner ear cells, and even in the more aggressive forms, we don't have any experience with corticoids. So first we have to establish that the hearing loss is due to the otosclerosis, and then we try the regular treatment for otosclerosis, but it doesn't involve corticosteroids. This is my opinion. I don't know if any other guys do corticoid for otosclerosis.
Yeah. Did he say that? Fine. Okay, we'll do that.
But I mean for the pain of the inner ear, not it's of course the cause is the otosclerosis or the degeneration of the problems of the bone, but the inflammatory process, if it could be improved with the corticoid therapy. I think that was my ask.
I understood, but until now I have not seen a so acute form of otosclerosis to promote acute hearing loss. So it's you are right, can be very progressive, but well, we don't have this kind of experience. We use corticoids when there is acute aggression, of course, and they said in the surgery, but in the normal evolution of pathology, we don't use. Okay, thanks.